Every single day, millions of people wake up, swing their legs out of bed, and feel it. That sharp grinding sensation in the knee. Not a sudden injury, not a dramatic fall. Just pain that showed up quietly and refuses to leave. They limp to the bathroom. They grab the railing going downstairs. They avoid squatting, avoid kneeling, avoid stairs when they can. And inside their heads, the same thought repeats. My knees are worn out. I'm going to tell you why that belief is wrong. In my 15 years of clinical practice, I have examined thousands of patients complaining of chronic knee pain, and in roughly 90% of those cases, the knee itself was not the primary problem. The pain was real, the limitation was real, but the source, the actual mechanical failure causing that pain, was happening somewhere else entirely. And because conventional medicine focuses exclusively on the site of pain rather than the system producing it, patients spend years treating the wrong thing. Here's what nobody tells you. Your knee is not a standalone joint. It is the middle segment of a three-part chain. Your hip, your knee, your ankle. When the hip becomes weak or unstable, when the ankle loses mobility, your knee absorbs forces it was never designed to handle. It becomes the victim of dysfunction happening above and below it, and that victim screams in pain while doctors x-ray it, inject it, and eventually discuss surgery, all without ever asking why it's being overloaded in the first place. The healthcare system is not built to find root causes. It is built to treat symptoms at the site of complaint. There is no billing code for examining hip strength during a knee pain appointment. Your orthopedic consultation will include knee imaging, possibly an MRI, maybe a cortisone injection. What it will not include is a functional assessment of your hip stability or ankle mobility, because those take time, require manual examination, and don't lead to lucrative procedures. Subscribe to Dr. Waterling right now and hit that like button. We're building this channel on one principle, giving you the information that a 15-minute orthopedic appointment will never cover. Every subscriber moves us closer to 1,000, and every single one of you helps us reach people who are being told their only option is to live with pain or go under the knife. Let me explain exactly what's happening inside your body. Your knee joint is a hinge. It bends and straightens. That's it. It has roughly 10 degrees of rotational capacity, but its primary job is flexion and extension in a single plane of motion. Now compare that to your hip. Your hip is a ball and socket joint with motion in every direction. Forward, backward, sideways, rotation. It's designed to be mobile, strong, and stable all at once. Here's the problem. After age 40, the average person loses between 1 and 2% of muscle mass every single year. That loss is not evenly distributed. The muscles that stabilize your hip, specifically the gluteus medius and the deep hip rotators, atrophy faster than almost any other muscle group in the body because most people spend the majority of their day sitting. When you sit, your hip flexors shorten and tighten. Your glutes lengthen and weaken. Over time, your hip loses its ability to stabilize your pelvis during movement. Now, when you walk with a weak, unstable hip, your knee has to compensate. Imagine a door hanging on loose hinges. Every time it swings open, it wobbles. It scrapes the floor. The latch doesn't line up. That's your knee when your hip can't control the femur, the thigh bone. The femur rotates inward. Your knee collapses medially toward the center line of your body. This misalignment creates abnormal pressure on the cartilage, abnormal tension on the ligaments, and abnormal strain on the tendons. Your knee is not diseased. It is being mechanically destroyed by forces it cannot control. At the same time, look down at your ankle. That joint is supposed to provide 20 to 30 degrees of dorsiflexion, the ability to bring your shin forward over your foot. Most people over 50 have less than 10 degrees. Tight calves, stiff Achilles tendons, years of wearing rigid shoes, all of it robs your ankle of mobility. When your ankle can't move properly, your knee has to move excessively to compensate. You end up with hyperextension, valgus collapse, and rotational stress, all because your ankle refused to do its job. So here's what actually happens. You walk into an orthopedic office. You say, "My knee hurts." The doctor presses on your knee, moves it around, orders an X-ray. The X-ray shows some cartilage thinning, maybe a bit of arthritis. You're told, osteoarthritis, normal wear and tear for your age. You're given a prescription for anti-inflammatories, maybe a referral to physical therapy that will focus on strengthening your quadriceps, the front thigh muscle. And you leave thinking your knee is broken, but nobody checked whether you can stand on one leg without your hip collapsing. Nobody tested whether your ankle can dorsiflex enough to squat properly. Nobody asked whether you've been sitting 10 hours a day for the last decade, because the system doesn't look at movement, it looks at imaging, and imaging shows the damage, not the cause. Here's the truth: knee pain is a symptom. Hip weakness and ankle stiffness are the disease. Treat the symptom, and you get temporary relief followed by inevitable progression. Treat the disease, and the symptom often disappears on its own. I want to tell you about a patient named Gerald. He was 58 years old when he came to see me. He'd been dealing with right knee pain for 3 years. He'd tried physical therapy twice. He'd received 2 cortisone injections. He was taking ibuprofen daily. His orthopedic surgeon had shown him the x-ray, pointed to the narrowed joint space, and scheduled him for a consultation about partial knee replacement. I asked Gerald to stand on his right leg. He couldn't hold the position for 5 seconds without his hip dropping and his knee buckling inward. I asked him to squat. He barely made it halfway down before his knee dove toward the midline and his heels lifted off the ground. His knee hurt because his hip was weak and his ankle was stiff. The knee was just caught in the middle, absorbing punishment from both sides. I did not give Gerald a knee brace. I did not inject his knee. I gave him a targeted hip strengthening and ankle mobility protocol. Within 3 weeks, his knee pain had decreased by roughly 60%. By 8 weeks, he was hiking, squatting to pick up his grandchildren, and sleeping through the night without waking from pain. His x-ray still showed cartilage thinning. But his knee no longer hurt because it was no longer being destroyed by compensatory forces. Now, how do you know if this is happening to you? Here's a simple test. Stand in front of a mirror in shorts or lightweight pants so you can see your legs clearly. Stand on your right leg. Lift your left foot just a few centimeters off the ground. Watch your right hip. If it drops on the left side, if your pelvis tilts, if your knee collapses inward, you have hip instability. Your gluteus medius, the muscle on the side of your hip responsible for keeping your pelvis level, is weak, and that weakness is likely torturing your knee every single step you take. Now test your ankle. Sit in a chair, feet flat on the floor. Keep your heel down and try to lift the front of your foot as high as possible. If you can't bring your toes higher than 20 or 30 degrees, if you feel a hard stopping point in your calf or Achilles tendon, your ankle has lost dorsiflexion. That stiffness forces your knee into compensatory patterns every time you walk, climb stairs, or stand from a chair. So what do? You rebuild hip strength and restore ankle mobility, not someday, not after surgery, right now. Here is your complete protocol. For hip strengthening, you need 3 exercises targeting the gluteus medius and deep hip stabilizers. Exercise 1, the clamshell. Lie on your right side with your knees bent at 90 degrees, feet together. Keep your feet touching and lift your left knee toward the ceiling, opening your legs like a clamshell. You should feel a distinct contraction on the side of your left hip, not in your lower back. Hold the top position for 2 seconds. Lower with control. Perform 15 repetitions on each side. If this feels easy, place a resistance band around your thighs just above the knees. The band should create enough tension that the final 3 repetitions feel challenging but not impossible. Exercise 2, single leg standing with hip abduction. Stand next to a wall or sturdy surface for light support if needed. Stand on your right leg, keeping your pelvis level. Slowly lift your left leg out to the side, approximately 30 to 45 degrees. You are not trying to kick high. You are trying to activate the right hip stabilizers to keep your pelvis from tilting while you move the left leg. Hold for 5 seconds. Lower with control. Perform 10 repetitions on each leg. As you improve, remove hand support and perform the exercise freestanding. Exercise 3, the glute bridge with hip abduction hold. Lie on your back, knees bent, feet flat on the floor, hip width apart. Place a small ball, a rolled towel, or a yoga block between your knees. Squeeze the object gently. Now lift your hips toward the ceiling, engaging your glutes and keeping the object compressed between your knees. Hold the top position for 10 seconds, maintaining steady pressure on the object. Lower with control. Perform 12 repetitions. This exercise simultaneously strengthens the glutes and activates the inner hip stabilizers that prevent knee collapse. Perform this hip strengthening sequence once per day, every single day. It takes approximately 8 to 10 minutes. The exercises are not glamorous. They will not leave you sweating or breathless, but they will rebuild the stability your knee desperately needs. Now, ankle mobility. You need 2 daily interventions to restore dorsiflexion. Intervention 1, the wall ankle mobilization. Stand facing a wall, approximately 1 foot away. Place your right foot forward, heel on the ground, toes pointing straight ahead toward the wall. Keeping your heel down, bend your right knee and try to touch it to the wall. If your heel lifts before your knee reaches the wall, you lack adequate dorsiflexion. Move slightly closer to the wall and repeat, pushing gently into the stiffness. Hold the stretch position for 2 seconds. Release. Perform 15 repetitions on each ankle. Over time, you should be able to stand farther from the wall while still touching your knee to it, indicating improved mobility. Intervention 2, the calf and Achilles soft tissue release. Sit on the floor with your right leg extended. Place a massage ball, a lacrosse ball, or a tennis ball under your right calf muscle, approximately halfway between your knee and ankle. Apply moderate pressure by resting your left leg on top of your right. Slowly point and flex your foot 10 times while the ball presses into the muscle. Move the ball to a different spot and repeat. Cover the entire calf and the Achilles region just above the heel. Spend 3 to 4 minutes per leg. This breaks up adhesions, reduces tissue stiffness, and restores sliding capacity between muscle layers. Perform the ankle mobility sequence once per day, preferably in the morning before you start moving. Your ankle will resist at first. That is normal. Consistency, not intensity, is what creates change. Now, here's your complete daily implementation schedule. Morning, immediately upon waking, wall ankle mobilization, both ankles, 15 repetitions each. Calf soft tissue release, both legs, 3 to 4 minutes total. This prepares your lower body for the mechanical demands of the day. Evening, before bed, hip strengthening sequence, clamshells, 15 repetitions per side. Single leg standing with hip abduction, 10 repetitions per side. Glute bridge with hip abduction hold, 12 repetitions. Total time, 8 to 10 minutes. That is the complete protocol. 0 additional equipment required beyond a resistance band, a small ball, and a wall. No gym membership, no expensive devices, just targeted, specific daily movement that addresses the actual source of your knee pain. Within the first week, most people notice improved stability when standing on one leg. By the end of 2 to 3 weeks, knee pain during daily activities typically decreases noticeably. By 6 to 8 weeks, many people experience near complete resolution of pain they've carried for years, all without ever directly treating the knee. Now, I need to be clear about something. If you have knee pain accompanied by significant swelling that appears suddenly, if your knee locks or catches and you cannot fully straighten it, if you heard or felt a pop followed by immediate severe pain and inability to bear weight, those are signs of acute injury requiring immediate medical evaluation. Ligament tears, meniscus tears, fractures, these need professional diagnosis and treatment. Everything discussed today supports chronic mechanical knee pain from compensatory dysfunction. It does not replace acute injury care. Similarly, if you are currently taking blood thinners, if you have a history of deep vein thrombosis, or if you experience calf pain with swelling and warmth, do not perform aggressive soft tissue work on your calves without medical clearance. Work with your physician to ensure the protocol is safe for your specific situation. But for the overwhelming majority of people experiencing chronic knee pain without acute injury, without structural damage requiring surgery, this protocol addresses the root cause. Your knee hurts because your hip is weak and your ankle is stiff. Strengthen the hip. Mobilize the ankle, and your knee, that innocent victim trapped in the middle, finally gets the relief it's been begging for. How old are you? Write it in the comments. I want to see which age group makes up the majority of our viewers, because it will directly shape what I cover in future videos. If this video helped you, send it to someone you care about, a parent, a friend, someone who's been limping around convinced their knee is worn out. You may have just given them a real chance to avoid surgery and reclaim movement they thought was gone forever. Subscribe to Dr. Waterling, hit that like button, and help us reach people who deserve to know that knee pain is not a life sentence. It's a signal, and now you know exactly what it's signaling.